Hi, Ibrahim.
I'm Peyton.
And I'm Matt.
And our advisor is Professor Jeff. So a bit of background on our sponsor. Brigham and Women's Hospital is a pretty large teaching hospital here in Boston. They're affiliated with partners, so that means beyond providing radiation therapy for just their own patients, they also provide therapy for Dana-Farber and Boston Children's patients as well. Before any patient receives radiation therapy, they must get a CT scan, also known as a simulation or a sim. And it's called a simulation because it's basically used by physicians to simulate the process of treatment and get the exact location and dosage of the radiation. So the reason for action, why we're actually doing this project, the current schedule of the CT scans does not fit the needs of both patients and physicians. Patients often have trouble finding appointment slots, which downstream can eventually lead to delaying their actual treatment. And physicians, they are spending a lot of time just coordinating these appointments. In addition to that, the demand for simulation is expected to increase about 5 to 10% each year, and their current schedule cannot accommodate this growth. Also, a key concern from Brigham and Women's is that only 60% of their appointment slots are actually being utilized, and this is mainly due to the inflexibility of their current schedule. And lastly, there are a few resource changes upcoming. One of the 2 CT scanners is going to be offline from February till May, and then they're also adding a new MRI next summer. And the current schedule, again, cannot reflect these changes. So the goal of our project is to build a CT scan scheduling tool that fits the needs of both physicians and patients. The optimal schedule should be relatively automated so that it lessens the burden on physicians, schedulers, and patients. It should also be flexible enough to accommodate for those new resources as well as the growth that I had mentioned. And then, as per request of our sponsor, the financial clearance and consent processes, basically everything before the simulation itself, is outsourced for this project.
So once the patient books their schedule for their CT scan, they go into the radiation oncology center, and at that time the patient either has their consent already done or they still need their consent. So if they still need their consent, then they go to meet with the physician, and this process takes about anywhere from 5 minutes to an hour or more, depending on the severity of the cancer, the patient type, and where the cancer is located. So once they have that consent, they move on to the change and prep and move into the simulation room, where the radiation therapist fits the patient for the type of equipment that they will be using for the simulation. So, for example, this is a mask which would be used for a CNS patient or a brain cancer patient. So once that is fit and everything's screwed down and in place to make sure that they have limited movement so that the physician can replicate it for the treatment, the patient goes into the CT machine to be scanned, and then that piece of equipment will be used with them throughout all the treatment. So also, like Natasha mentioned, the pre-simulation work is not included in the scope of our project, and we're solely focusing on the actual simulation process and the simulation schedule. So this is what currently the simulation schedule looks like. It's updated about every 6 months and is pretty fixed right now, and it's has 1 hour time slots throughout the day. So the spots in white are reserved for specific doctors, so we just took out the name for privacy reasons, but various doctors are noted by different letters. But if a doctor doesn't fill their spot within 24 hours prior to the appointment, the spot becomes an open appointment, similar to the ones marked as open, which just means that they're unreserved spots and anyone can take them. And then the blue spur spots are used for urgent care patients, which are typically filled within that same day. So if there is no urgent care patients in that day, then those spots go unfilled. And then the CNS appointments they're more straightforward scans, so they can be done in 30 minutes as opposed to the hour. So for these grad appointments, there's actually 2 appointments within them, 2 30-minute appointments in them. And then the various screening thoracic appointments are just cross-coverage appointments by various physicians, and the different color, different shading represents the pre-simulation work done for it. And then currently, this schedule is there's a total of 90 spots, but currently the Radiation Oncology Center is only utilizing about 55 to 65 spots per week. So Brigham Young Women's knows that there's an issue with appointments starting on time, so they really want to increase that start time. So they did some past research to kind of just do some time studies to see where the appointments actually were, which is denoted by the yellow data points. So they found that patients were arriving late, so they implemented an hour prior spot. So you could just have patients show up an hour prior to their appointment. So if you have an appointment at 10, just show up at 9 to be able to get the contrast, or just have like the waiting time that you need to be able to start your simulation on time. So there was an increase in that, as shown by the red data points. Fewer people were arriving late, and also except for the pre-consent appointments, because like I said before, those have a lot of variability, but that's also out of our scope.
So in terms of target state, like we said at the beginning, the goal is to increase the utilization of the appointment slots. So as we reiterated one time, 60% is being used now. We want to be closer to 85, 90. The only reason we don't want to be at 100% is because we have those urgent spots that are held until the point of the appointment. And in the future, what they want to do is decrease the simulation times for the 60-minute appointments. So those will come down to 45 minutes, so you'll have an increased capacity. So it's important for them to update their schedule now so they can increase that utilization when they have a higher capacity. So we've done a bunch of literature review. Obviously, industrial engineering is pretty big in healthcare, and particularly appointment scheduling in the last few years. 3 of the things that we focused on in terms of papers were a sim heuristic framework paper, which used a meta heuristic optimization method to schedule 2 different types of patients throughout an 8-hour day. And the goal was to minimize an average length of stay, and we think that's probably one of the methods that we'll focus on. We use Capstone 2 and explore possibly using that. The other 2 were a bit more complicated and won't exactly fall into the scope of our project, but it was helpful to see what people have done in the past, if it could have been applied to our project. So our preliminary analysis, we've done a bunch of qualitative and quantitative data analysis. We had about 18 months of historical data, so it included 4,700 scans and 86 different cancer sites among them. In the graph on the right, you'll see the distribution of 30-minute and 60-minute appointments. About 17% are 30 minutes, the other 83% are 60 minutes. And of all of these patients, so the whole 4,700, about 40 to 50% of them need their actual physician to be there. So breast cancer patients, for one, their physicians have to be there. One of the things that Brigham Women's is thinking about doing is implementing a generalized coverage model. So there'd be one full-time physician who covers both CT scans and is able to handle the other 60 to 50 or 50 to 60% of the patients that don't need their actual physician to be there. So he or she could analyze each of the scans and work for all the other patients. You can see there a bunch of other qualitative analysis. And for the urgent appointments, obviously there's no assigned doctor for an urgent appointment, so they're covered by a 2-week rotation.
So the simulation model is an important part of our project. We chose to build an Encineo because of the many features it provides and the powerful animation capabilities. There are main objectives for the simulation model. First, we wanted to replicate the existing system, and we wanted to build a simulation model based on that, simply because this is how it works right now, and this is how our solution is going to be. For the second objective, we wanted to replicate the current system based on cloud. So this simply means replicating the process performance in terms of inefficiencies and utilization. And our third objective is using our solution, using the model to test our solutions and that can be in terms of a new schedule or actually changing scenarios, like adding a CT scan or removing one, and playing with it or adding uncertainty to see how it changes. So for capstone one, we wanted to achieve one of the objectives is start the simulation model, and we started with the patient arrival based on a scheduling method because it seemed like a natural way to start and build our model from. So to do that, we created two data tables in Simio. The first is a patient information table, which basically lists the patient types. And as you can see, it's general, CNS, or green, open, or urgent. And alongside that is a patient simulation table, which basically means how long that patient is going to occupy a room. For our second table, it's basically where our schedule is going to be. And as you can see, an arrival time or an appointment start time. And the schedule that you can see right here is of a Monday schedule of the existing system or the existing schedule. And in the column next to that specifies which patient type is arriving for that appointment. And this is basically linked to the first table, which is going to determine how long that patient is going to occupy the room. And this is like a quick video of our current initial simulation model. And as you can see, at 8 a.m., 2 patients arrive. And they occupy the room for around 1 hour. At that time, it's dependent on the patient type.
So in terms of path to solution, our goal is to create two models. So one had to be the distribution of 30 and 60 minutes, the second being 30 and 45 minutes. And what we'll do within each of those models is test a bunch of different iterations for scheduling distribution. So we could have CNS appointments in the afternoon, and then a bunch of open appointments before that, or however we want to test those models. And then finally, just the generalized coverage model, we want to test that 50% of appointments that can be covered by a general physician, and what Brigham and Women's thinks about implementing that model. So just a quick look for our outlook for capstone 2. We want to create those two models, like you said. We want to continue to shadow the physician and therapist because we found that's the most helpful way to figure out what they want and how particularly the therapists feel about this current schedule. And most importantly, we want to deliver a preliminary model to Brigham and Women's before the end of capstone 2. That way we can incorporate any feedback from them prior to our final look. That's it. Thank you.
So help me understand this a little bit. You have a system where individual physicians and different kinds of tests are scheduled in different slots through the days. So you basically have the initial schedule is very segmented, right? And how far in advance are these things done?
So they have to book it at least 24 hours before. There are times where they book it 6 months ahead of time.
Okay.
And there's times where if there's an open slot, they can book it that day.
Right, so you have open slots.
Yeah.
In fact, you're saying they open up 24 hours before if they're not used.
Yeah.
So you've got a bunch of slots opening up, and the issue that you're dealing with is both the underutilization and the fact people can't, despite the fact it's underutilized, they can't get slots.
Yeah, so a lot of times people are either arriving late or their pre-consent work is taking double the time that they expected. So they've implemented this past policy, but it's still not utilizing the appointments in the sim as much. So we found that a lot of the problems occur in the pre-sim work, but our scope is just to create that appointment schedule.
Just to create the appointment schedule better, yeah. Because I may be misunderstanding it, but it seems like that kind of system is going to have a lot of problems with the longer, the further ahead systems, because some of those slots are going to fill up for months and others will just remain empty. So you're underutilizing it that way. Does your simulation sort of handle that aspect, or is it only kind of the hour by hour aspect of the operation of the room?
Well, yeah, it's basically on the hour to hour, and it's just based on the existing schedule that they have right now. And our solution will be implemented in the simulation model. So that will change in our simulation, and we're going to see the effects of that and what the results are going to be, along with changing certain scenarios as mentioned, like the MRI constraint or the change in the number of CT scans.
But you're not going to try to simulate the issue of trying to get appointments like months ahead of time. You're not going to look at like the month long queues and different
This is something
strategies
that
for
has-
handling those.
Yeah, this is something that has been discussed with our sponsor, and
Mhm.
they asked us to assume that each appointment is going to arrive on time. So in that specific, so anything that happens before that, or how that appointment is being booked is something out of scope. So just the
Okay.
appointment slots and assuming each patient is arriving.
Okay, that. I'm a little bit worried you're not addressing what the actual problem is, but we can talk about that, offline. Don't want to take up all the time here.
So the main point of underutilization of the equipment is that coming from the delay of the arrivals or majorly coming from the variability of the service time, the usage time of the machine. So these are two different aspects of uncertainty, right? So in your simulation model, if you are more focusing on the first part, then you have to kind of come up with probabilistic distribution of this arrival time and delay distribution, and improve your scheduling or appointment scheduling from that point. Kind of, I don't catch which one is the major pain point.
Yeah, I completely agree, and that goes into the main, second objective actually, which is replicating the existing system in terms of its inefficiencies and how it works right now. The first objective which we worked on is just creating a simulation model that, to an extent, resembles the existing model and is based on a schedule. And our second objective, we're going to work in actually incorporating all of these inefficiencies and basically trying to make it as accurate as possible and validate our model based on these things.
And to answer your point on service time, the service time is not an issue. Like, we went there and observed it several times, a bunch of scans. They're all completed within a 60-minute period. So that's why they're coming down to 45, because the service time isn't the issue, which we highlighted too. So, yeah, we just need to update the current inefficiencies. Pretty simple.
I'll ask this question. You don't have to answer it, but make sure you do. And I'm saying it for the sake of the other teams as well. You've done some literature research, so be sure to outline what's already out there for this type of problem and why your system is different and needs your attention on it. What's unique about this system. So any of you have a project that you're doing some metrics on or changing or making a solution. What's been done in the past in other hospitals and other similar systems, and what's different about yours that you and so I think we have to stop there so you don't have to answer me right now. Let's talk about that.